Hello, my name is Dr. Dewan S. Raja. Today I will discuss about hemochromatosis. Hemochromatosis is an excessive iron deposition disorder. We need iron. Most of the iron we absorb is excreted, but in hemochromatosis there will be deposition of iron in our system. This is an autosomal recessive disease. There will be increased accumulation of iron affecting multiple organs like the liver, pancreas, heart, thyroid gland, maybe parathyroid gland, adrenal gland, skin, joints, testes, ovaries, kidneys, and the pituitary gland. There will be dysfunction of these glands due to excessive accumulation of iron. More common among the white population of North European ancestry, in male in their 50s, in female in their 60s. In female, this disorder is manifested after 10 to 15 years, followed by the menopause. In female, it is manifested late because of normal menstrual cycle and loss of blood. So loss of blood means loss of excessive load of iron in the system. So the manifestation in female is delayed 15 to 20 years after menopause. Genetics, there's mutation in HFE gene and they are homozygous for C28-2Y, that is more severe. This is the mutation of this gene HFE that is present in chromosome number 6 or H63D, or a compound heterozygote containing this and this together. In some patients, it may be non-HFE hemochromatosis. There are two types, primary and secondary. Primary is the hereditary hemochromatosis and acquired is the secondary hemochromatosis. Acquired due to repeated blood transfusion, that is in beta thalassemia major. Even in some other myelodysplastic disorder like sickle cell anemia or other hemolytic anemia, due to repeated blood transfusion, there will be excessive load of iron in the system. What is the pathogenesis of hemochromatosis? Lower hepcidin or diminished hepcidin function. What is hepcidin? Hepcidin is a circulatory peptide hormone that is produced in the hepatocyte of the liver that is a negative regulator of iron absorption. Excessive iron will damage the parenchymal cells by lipid peroxidation that is mediated by the iron-based radicals. So by lipid peroxidation and proliferation of collagen synthesis. There will be tissue deposition of hemosiderin, there will be DNA damage and predisposition for hepatocellular carcinoma. Many endocrine glands are affected, so there will be endocrine insufficiency. It may include the pituitary gland, the thyroid parathyroid gland, the adrenal gland, the gonad, the testis or ovary. So here we are looking at the hemochromatosis. These images are taken from Robbins-Cotton pathologic basis of disease. Here the liver biopsy by Prussian blue staining, looking this bluish color is the deposition of iron. In this specimen, the architecture has been lost has not been lost, but in case of advanced cirrhosis of liver, this architecture will be lost, hepatocyte will be damaged, and there will be excessive collagen or fibrosis. What happens? Normal iron absorption. This is the hepcidin. There is a hepatocyte. There is the parenchymal cell of the liver. Okay, and this is the normal ferritin. Hepcidin has negative regulatory action on the enterocyte. This is the lining epithelium of the duodenum, jejunum. Okay, so where iron is absorbed. So there will be interaction of hepcidin with that of the ferroprotein. So iron will be regulated to be fluxed in here. Okay, that is required in normal cell, but in hemochromatosis, reduced hepcidin, excessive ferritin, and hepcidin and ferroprotein reaction does not occur. There is no negative regulation, so iron will be overloaded like this. So this is the pathogenesis of hemochromatosis. So what is the clinical presentation? It is asymptomatic in the early stage. So it usually does not manifest in the childhood. Okay, it may happen in the neonate, but that may be different pathology in the uterus. It is usually manifest around the age of 50 due to excessive accumulation of the iron in the system. There will be hepatomegaly, initially hepatomegaly, but when the cirrhosis is established, the liver may be squeezed. And there will be abdominal pain initial days, okay? Atypical arthritis because of deposition of iron in the articular cartilages, loss of libido, testicular atrophy, specifically in male, there will be loss of libido. Decreased glucose homeostasis, so fasting blood sugar level will be high. Okay, this happens because of damage to the pancreas, and pancreatic islet cell may be damaged. Pancreatic acinar cell may be damaged. There may be pancreatic insufficiency, islet cell damage, beta cell damage, so that may lead to diabetes mellitus. Okay, so cardiomyopathy, there may be enlarged heart, cardiomyopathy, and there may be arrhythmia. Abnormal skin pigmentation, the reasoning is that it may be due to excessive melanocyte secretion, or it may be deposition of hemosiderin, or both together. What are the laboratory tests? Transferrin saturation, serum ferritin. Transferrin saturation study should be in hemochromatosis maybe more than 50%. Serum ferritin will be high. Genotype of the person with the mutation, you can easily assess that. Liver biopsy, okay, we'll see the deposition of iron. Fasting blood sugar and assessment of testosterone because the testes will be atrophied and small. Luteinizing hormone, follicle stimulating hormone, because pituitary gland may be affected. Treatment. The goal of therapy is the removal of excessive iron load. The therapy includes phlebotomy, that means letting the blood out from the vein, phlebotomy. Chelating agent, phlebotomy blood is getting out, it can be stored, it can be used in other patients or the same person, it may be used if it is required. Chelating agent, deferoxamine, this is the antidote for the iron toxicity, iron overdose here, or excessive accumulation of iron. So that is the chelating agent. The chelating agent remove the heavy metal from our body, and this is the antidote also here. Avoidance of supplemental iron and excessive vitamin C is important to decrease the iron load. Phlebotomy is usually done once in a week. Phlebotomy may not be a good choice for a person who is taking too many blood transfusions due to some myelodysplastic disorder or like that of thalassemia. So in those persons, chelating agent may be a better choice. But avoidance of supplemental iron and excessive vitamin C is a good idea to decrease the absorption of excessive iron. Monitoring ferritin level is important. Monitoring the development of hepatocellular carcinoma. So not only cirrhosis, we may have in our patient may have hepatocellular carcinoma. Genotyping the first degree relatives, even in the young age, in the juvenile age. And that's all about hemochromatosis. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice day. Bye now.